Namrata we have now, the Chairman Scientific Committee, and one of the best scientific person the world has, and huge inventions, publications, teaching, research, name anything. She's one of the top women in the world.
Thank you, sir.
Okay, she's going to take us the one of the difficult part to do phaco in all these corneal problems, which she is expert. Dr. Namrata, please.
Thank you, sir. And I have no financial or proprietary interests. And always, I think, as cataract surgeons or as general ophthalmologist, you would want to know where you would do cataract surgery alone or you would combine it with a corneal transplant. And basically, if you're well versed with SICS, it is good to do that. But we all began learning ECCIOL and went straight over to phaco. So I try to do phaco alone rather than SICS in these cases. And the factors which determine whether you will do a single stage or combined procedure depends on the type of the corneal opacity of the haze, the location of the haze, the expertise of the surgeon, the availability of the donor corneas and visual requirement and risk-benefit analysis, and sometimes also the patient's own willingness as to whether the patient wants to undergo a corneal transplant or not. So, like I say always, that this one half of the cornea should be clear. So you can actually do phaco through the half of the clear cornea because you can see all the maneuvers and everything that is hiding underneath can be pushed here into the area of visualization. But this can be only done if the opacity is peripheral or paracentral, and if it is central, then it cannot be done because then it has to be combined with a corneal transplantation procedure, or if it is very superficial, then PTK or ALTK with phaco or DSEC-DMEC triple, depending upon whether endothelium is involved, and all layers, if PKP triple, all layers of the cornea are involved. In these cases, generally the intraocular lens is monofocal. We are trying to see whether EDOF or monofocal plus would make a difference or not in a study that we are conducting. Keratometry is often not possible, so I like to take a standard K. You can alternatively calculate it with the surgeon factor as well. Biometry is again often not possible. Biometry is done in these cases, but IOL master is often not possible in these cases because of the visualization, which cannot be done. Now, word about this Fuchs dystrophy with cataract, because there will always be a question, what will you do in such cases? So I go by this, that is, if there's poor view for visualization and for doing phaco, and if the CCT is more than 650, cells are less than 800, then we would combine it with a corneal transplant straight away. But if the view is clear and if the cells are less than 650, cells are less than 800, CCT is less than 650, then we can counsel the patient, do phaco, and then see whether the patient requires endothelial keratoplasty or not. And if there are no epithelial changes and the cells are good, the CCT is also okay, then you can do phaco alone. So here you will plan your incision. So first thing, before you sit on the microscope, you see which side the incision has to be made. So for instance, if it is like this, then temporal incision is better. But if it is like this and this is the head end, then superior incision is better. Again, to show this case of corneal opacity, but here it is not that difficult because the opacity is bang on and it is a leukomatous opacity. There's hardly any scattering which is there from the peripheral part. And when this occurs, then actually what you need to do is just initiate your rhexis from the area which is relatively clear. In the clear part of it, you can do phaco as you would do normally. And as you come to the part where the haze is present, then again, like I said, everything has to be brought into the area of visualization. So keep lollipopping the fragments of the nucleus or the cortical matter with the help of the second instrument into your phaco probe or into your eye irrigation aspiration probe. And once the cortical aspiration is done, always and almost always, you put the intraocular lens and everything will appear a lot more brighter than what it was before because the refractive error gets neutralized. Again, this case was a one-eyed patient, didn't want to go a corneal transplantation, but this case highlights all the things that you should undertake. For instance, here, this is the temporal incision. This half of the cornea is clear. Then stain with trypan blue dye, and then push the globe a little bit to see the edge of the rhexis there. And when you come in this area of the haze, then go in one go. Now there's an optical iridectomy there, so eccentric rexus and eccentric crater. And when you do eccentric crater, always remember to put your retroillumination on, because when you put your retroillumination on and do phaco in situ, that means you phaco and you eat, you phaco and you eat. So as the red reflex gets better and better, you will be able to see better the grayish and the whitish nuclear fragments. And then again, the second instrument plays a very important role here whenever the corneal opacity is there, because everything that is underneath this has to be brought to the area of visualization. And then sometimes, like I said, when you start to put the lens, you can actually see the edge of the rexus there, and then place the lens inside as well. With the Care Group company now, we are working also with the intraocular lens with asymmetric haptics, because especially in optical iridectomy cases where you don't plan corneal transplants. Very much similar to the case that I showed earlier. Only thing is now here you have to put nylon hooks here to expand your area of visualization, and again follow the same principles. Temporal here, this half is clear, so you can do your eccentric rexus, eccentric here, it was central rexus which was done, but eccentric phaco can be done from this area of visualization. Now this is yet another technique. What keeps happening is that when there's haze present, you try to phaco here in the center, and the nucleus keeps springing up and keeps coming inside, doesn't allow you to chop. So what you do is you do these peripheral chops first, so the nucleus is no longer taut and it kind of breaks down. This is just to show the case like this. So what is basically done is that after doing rexus, give peripheral chops. So when you give those peripheral chops, it will not keep springing up into the capsular bag, and it will kind of get paralyzed, and then one of these wedges can be removed, and then the rest of the wedges will follow. So this is a small trick just to see that your cataract doesn't keep coming up and impede your chopping maneuver. Now this is a black and a white cataract. Black because it is tattooed, and white because there's a corneal opacity. Again, notice that you have to expand your area of visualization, nylon hooks, then you have to use dispersive viscoelastic agent, then you have to do rexus. Don't leave the edge of the rexus here. Here, the edge of the rexus was lost, but we could pick it up through the intraop OCT microscope. And then the same thing, phaco in situ, so you keep getting the red glow to become better and better by keep eating the nuclear fragments. And then notice that this is so much better as compared to what we started with. And once you put intraocular, once you put the IOL, then it becomes again a lot better. And then I do what is called as the pilocarpine test. So what I would do is I would put pilocarpine to see where it is constricting, and if I need to, then I would even do a sphincterotomy or expand the area of visualization if required. We did publish this new surgical approach in Steven Johnson cases, and this I'm showing because these are high-risk grafts. And here again, temporal incision, nylon hooks, endoilluminator inside the eye to see where you are chopping, because that helps you to brilliantly see it. And now endoilluminator outside the eye to see where actually the lens is going, and then these nylon hooks can be removed. If you do corneal transplants for SJs, then they're sure to fail. So this is the post-operative result with good results. I'm not saying an eagle's eye vision, but for the patient to become functional and for the patient to actually do his or her daily activities. Again, this is a case where pannus was there, and we removed the pannus, and sometimes you can be really surprised, and like I always say, that eye is over there and you have to dig it out. So you dig out the eye from here, so remove the entire pannus bit by bit, tease every fragment. It is it requires a lot of patience. And then here chandelier has been put, and once you put a chandelier, you're completely in a different world of visualization, different world of also doing surgery. Because when you do surgery, it feels differently. And then subsequently, now because it has become a lot clear, so you can shuttle between the chandelier and the normal operating microscope light, and rexus is being done here, which can be very clearly seen. Then once you put the chandelier on, everything brightly illuminates. Otherwise, it becomes difficult to see. So phacoemulsification is done, irrigation aspiration is done, intraocular lens is implanted in the bag, and I also also inside the bag. And then just see, just to show the pre and the post-op picture, sometimes, like I say, you have to dig it out from to see where the patient can see from, because the patient hops from surgeon to surgeon, but if nobody does a case in these eyes like this, then we will not be able to give vision to the patient. Then femtocataract and corneal haze, and I'll just show this last video to show, I think it has a huge role to play. It is fill in the blanks. So it'll cut some places and not cut some places, but that doesn't matter. So you have to fill in the blanks. Rexis is not here, so you just fill it up. CHOP is not here, so you just do it manually by rotating it. I think, again, it has an important role to play and it works well. Again, this paper is already accepted in JCRS to be published. This I will skip because this is the beyond the control of the cataract surgeon alone and requires corneal transplantation. But the algorithm that we have come with and we have published in JCRS as a review article, cataract surgery with corneal opacity, you can do phaco alone or with optical iodectomy or even PTK with phaco. And depending upon where the opacity is and if it is central, then SALC triple, ALTK triple, DALC triple, DSEC DMEC triple or PKP triple, and this is published in JCRS as a review article. So to conclude, in high-risk cases, do phacoemulsification first, but those for good prognosis, do combined procedures, and always explain to the patient that ambulatory visual acuity is what we are looking at. And thank you very much for your kind attention.